as promised, here is the end of your lecture. We are focusing on Chapter 48, various diseases and conditions that can affect the kidneys. We're going to start off with urinary tract infection. So a UTI is a bacterial infection. Women are more susceptible, and E. coli is the most common pathogen that's found when they do a urine culture. So basically you take a urine sample from a patient. You would initially dip that urine sample to see what comes back on the dipstick. If the dipstick was positive, meaning there was leukocytes, nitrates, and blood on the dipstick, then you could send the urine for culture. And then the most common pathogen that's found is E. coli. We treat urinary tract infections with antibiotics. UTIs can be in the lower or upper urinary tract. Pyelonephritis is inflammation of the renal parenchyma and collecting system. It begins in the urethra and bladder and then travels up to the kidneys. This is a type of UTI that specifically affects the kidneys. Cystitis is inflammation of the bladder, and urethritis is inflammation of the urethra. This is just the patho of a UTI. So initially, colonization occurs down here in the urethra. The pathogen colonizes the urethra area and then ascends upwards towards the bladder. Once it penetrates the bladder, bacteria continues to replicate and form many biofilms. After that, once sufficient bacterial colonization occurs in the bladder, bacteria may start working its way up the ureters towards the kidney. Once it hits the kidney, that's when we can have a diagnosis of pyelonephritis. It causes an inflammatory response, and while infection of the renal parenchyma is usually the result of bacteria that ascends up, it can also occur from spread. If we do not treat pyelonephritis, the patient can develop an acute kidney injury because the inflammatory cascade that is happening continues. Tubular obstruction and damage may occur, leading to interstitial edema. This may lead to interstitial nephritis and cause an acute kidney injury. The clinical manifestations include dysuria, or pain while peeing, frequency of urination, suprapubic discomfort or pressure. When you take a urine sample from the patient, you may actually see visible blood or sediment, cloudiness, in the sample. And again, like I had mentioned in the previous slide, when you dip the sample, you might see leukocytes and nitrates become positive. As the UTI develops and starts working its way toward the kidneys, the patient may experience flank pain, either one-sided or bilaterally. The patient may develop a fever or chills. Older adults may not have any symptoms or may present with different symptoms than younger adults and children, such as confusion, low temperature, generalized abdominal pain, fatigue, and anorexia. It's important to note the differences in symptoms between the normal population and then the elder population. As a part of our nursing care, health promotions for a UTI is important. Emptying the bladder regularly and completely, evacuating our bowels regularly, wiping the perineal area from front to back after urination and defecation, drinking adequate amounts of water, encouraging the use of cranberry juice, and teaching about antibiotics. The most important thing in regards to antibiotics is that the patient take the complete course of antibiotics and not stop them despite them feeling better. Urosepsis is a systemic infection arising from a urological source. It can be life-threatening and can be often a complication from a UTI or a prostate infection in males. Urosepsis, or sepsis, is more common in women and more common in elderly women. The symptoms of sepsis are an increased heart rate, increased respiratory rate, sweating or diaphoresis, anxious, altered level of consciousness, and decreased urinary output. This can lead to septic shock if not identified and treated quickly. It's characterized by bacteremia or bacteria in the blood. The patient may have symptoms of urosepsis and show a change in their vital signs, like I said, tachycardia, tachypnea, and hypotension. They will then take a urine sample and send it off for culture, and they will also take blood cultures, which is where you will see the bacteria in the blood. Patients who have urosepsis are often admitted to hospital under close observation, and very close monitoring is required. They need a significant amount of antibiotics, IV fluids, and sometimes require oxygen. Moving on to urinary tract calculi, also known as stones. Crystals precipitate and unite to form a stone. Stone formation depends on metabolic, dietary, genetic, climatic, lifestyle, and occupational influences. It is more common in men than in women, and the peak age is 20 to 55 years. Stones can cause an obstruction with urinary stasis and infection. The patient with stones often presents with abdominal pain, flank pain, blood in their urine, nausea, vomiting, and fever. They're guarding the area, and their abdomen might be distended. Often, they'll present rocking back and forth from the pain. The diagnosis of stones, or kidney stones, is done through blood work, assessing the urine, and completing a CAT scan, or even an ultrasound. We can see these little stones on a CAT scan. Narcotics can be given to the patient to assist in pain until the stone passes or is surgically removed. This is just a picture of a gentleman and what he might look like, which is pretty darn close, if renal calculi is present. Stones smaller than 5 millimeters generally do pass on their own as long as the patient stays hydrated, and the main goal for this patient is to assist with pain management. Stones greater than 10 millimeters will generally not pass spontaneously and usually require a form of surgery. The size of the stone can be seen on a CAT scan. Urinary incontinence is something you learnt about in FHA and AHA. It's also known as uncontrolled loss of urine. It can be common in women after childbirth. There are various kinds of urinary incontinence. Stress, urge, overflow, and functional are some examples. Please review page 1317, table 48-17 and 48-18 because you will see one or two test questions on midterm B about urinary incontinence. This chart just shows you the various types of urinary incontinence: stress, urge, overflow. Again, 1 to 2 test questions will be coming from the chart in your textbook, but this chart is also useful. These are just a few stats on urinary incontinence. Health promotion for urinary incontinence includes weight reduction, reduction of bladder irritants such as caffeine, coffees, teas, fluid modification, putting a patient on a voiding schedule, also known as bladder training, and completing Kegel exercises. With the patient lying down, they can contract their pelvic floor muscles for 3 seconds, then relax the muscles for 3 seconds. Doing this 10 to 15 times several times a day can assist. We talked about acute kidney disease in class, and now I want to talk about chronic kidney disease and end-stage renal failure. Chronic kidney disease is progressive, irreversible damage to the nephrons in both of the kidneys. There are 5 stages. The level of severity depends on the GFR. End-stage renal disease, known as stage 5, often requires dialysis. Diabetes is one of the leading causes of kidney disease. Nephropathy is a complication. Over a period of time, high glucose levels and high blood pressure damage the kidneys and prevent them from functioning properly. As a result, the protein in albumin spills into the urine instead of being processed in the blood. Without treatment over time, the kidneys fail. Hypertension causes artery damage, and there are many arteries in the kidneys. Over time, uncontrolled hypertension causes arteries in the kidneys to narrow, they become weakened, and they start to harden. These damaged arteries are not able to deliver enough blood to the kidneys. They also do not filter well. This is a picture of a lady in chronic renal failure. She might experience headaches, a decreased ability to concentrate her urine, polyuria, which eventually will lead to oliguria, an increased BUN and serum creatinine level, edema, a progressively worsening GFR level, glomerular filtration rate, anemia, increasing blood pressure, weakness, and fatigue. As renal function deteriorates over time, excretory, regulatory, and endocrine function can be lost. Uremia starts to occur, which is the buildup of waste products and excess fluid. The patient's creatinine will become more and more elevated, as will the BUN levels. Electrolytes will change, especially potassium, which we will see increase. We will start to develop acidosis, as evidenced by our arterial blood gases, fatigue, anemia, nausea, fluid volume excess, because the kidneys are unable to excrete it, anorexia, decreased cognition, itchiness due to that buildup of toxins, and neuropathy. Some of the causes of chronic kidney disease is waste product accumulation as the kidneys fail, altered carbohydrate metabolism, elevated triglycerides, think of our cholesterol, electrolyte and acid-base imbalances, and infection. The effects are quite systemic, meaning it really does affect our entire body. It affects our hematological system because of anemia, and remember, the anemia is related to the erythropoietin production. The cardiovascular system, we start to see hypertension and congestive heart failure as fluid starts to build up. In the respiratory system, we see shortness of breath and fluid overload. Due to the amount of waste accumulation in the blood, the neurological system is affected and our level of consciousness is altered. The musculoskeletal system, integumentary system, reproductive system, and endocrine systems are also all systems that have changes associated with chronic kidney disease. So just a quick memory, there are two types of kidney failure, acute and chronic. Acute kidney failure develops within hours or days, and it includes a chance of kidney function recovery. Whereas chronic renal failure develops over many years, we cannot reverse it in the end. It's usually caused by high blood pressure and diabetes, like I've previously mentioned, chronic bacterial inflammation of the kidneys, polycystic kidney disease, or various autoimmune diseases. Over time, as we have chronic kidney disease, eventually we may lead ourselves into end-stage renal disease. The clinical manifestations for this patient would include polyuria, leading to oliguria, which is less than 30 cc's, and anuria, which is no urine. Metabolic waste product accumulation occurs. Our BUN and creatinine get even worse. We start to experience more and more nausea and vomiting, fatigue, and disorientation. We see several fluid and electrolyte imbalances in patients with end-stage renal disease. Because potassium can no longer be adequately excreted by the kidneys, our potassium level gets higher and higher and higher. This is very serious and can lead to fatal arrhythmias. Remember, although we can treat potassium levels conservatively through various medications such as calcium gluconate and insulin and Ventolin, if the potassium level is very high, the patient may require dialysis. The sodium level may be normal or low. Magnesium, calcium, and phosphate can all be disrupted. And the body cannot get rid of ammonia, leading to metabolic acidosis. Anemia results because of the decreased production of erythropoietin, hypertension related to sodium retention, an increased chance of developing an infection because the body cannot eliminate waste products, and cardiovascular and respiratory complications. Moving on, in end-stage renal disease, we have effects on the GI system, the neurological system, the musculoskeletal system, and the integumentary system, all related to waste product accumulation. The goals for patients with chronic kidney disease or end-stage renal disease are to preserve what renal function is left, treat the signs and symptoms, prevent complications, and provide comfort. Remember what I just said. What can we use for hyperkalemia? Think back and write those things down. For hypertension, we can use diuretics, beta blockers, and ACE inhibitors. And for anemia, we can help to stimulate the cells in the bone marrow to produce red blood cells. We need to make sure that the patient who has renal disease restricts the amount of protein in their diet. Although they can still have some protein, we do want it to be decreased. We need to have strict water restriction, sodium and potassium restriction, because the patient's already having sodium and potassium issues, and phosphate restriction. Restriction really depends on the excretion ability of the kidneys and what the patient's able to get rid of, and whether or not they are on dialysis or not. Other nursing interventions include health promotion and teaching, weighing the patient daily because they are at risk for fluid overload and congestive heart failure, monitoring their vital signs daily, especially their blood pressure, monitoring for signs of fluid overload such as edema, crackles in the lungs, shortness of breath, and teaching about the various dietary restrictions. If a patient gets to the point where their renal function is declining and their electrolytes are quite abnormal, the patient may need dialysis. There are two types of dialysis that are common to the kidney patient: peritoneal dialysis and hemodialysis. Peritoneal dialysis is a method of removing waste products and excess fluid from the blood using a natural semi-permeable membrane, also known as the peritoneum. You can see in this picture here, this is peritoneal dialysis. The catheter is going through the peritoneal space. Outside of the peritoneal space, there are two bags. One is the drainage, and one is the actual fluid. This fluid will go into the peritoneum, cleanse, and drain the toxins from the peritoneal space into the drainage bag. Hemodialysis removes waste products and excess fluid from the blood using a machine. The machine is like an artificial kidney. It pumps the blood through an artificial semi-permeable membrane. This is the patient on hemodialysis. Hemodialysis requires access, usually through the arm, via a fistula. Blood is removed for cleansing. It goes through this artificial-like kidney, the dialyzer. It is cleaned and then returned back to the body. The picture on this side shows you hemodialysis versus peritoneal. Peritoneal dialysis is a great alternative to hemodialysis because the patient can do peritoneal dialysis at home. There is a video. If you stop this audio recording and minimize your screen, you can watch the YouTube video on peritoneal dialysis. It's important to note for testing purposes the advantages and disadvantages of peritoneal dialysis. The good things are that the patient can move around. It's very efficient, and there's way more relaxed diet and water intake rules. We do not require vascular access through the arm, and the blood pressure is better controlled because we are not removing blood and putting it back in. The cons are that it's not really monitored that well. The patient can do it at home. This could also be a pro, but we do generally like to see follow-up in these patients. They can get dangerous infections called peritonitis. They can develop chronic back pain and anemia, and there can be some nutritional complications. It depends on the patient and the type of kidney disease they have and why it occurred in the first place as to whether or not they will receive peritoneal or hemodialysis. When a patient gets hemodialysis, there needs to be access to a large blood vessel. An AV fistula or graft is inserted into the brachiocephalic or radiocephalic area. Blood is removed, dialyzed, I always have trouble saying that word, and then returned to the patient. Again, if you minimize this video, you can watch 2 videos that I have posted here on how hemodialysis works. Remembering that for testing purposes, it's important to differentiate hemodialysis versus peritoneal dialysis and the pros and cons of each. So the pros of hemodialysis includes that it's very cleansing, but it has to be done 2 to 3 times a week, constantly monitored by a healthcare professional. The cons is that it can be really exhausting and painful for the patient to go through that 2 to 3 times a week. They really need strict diet and water intake. Fistulas can cause long-term vascular problems, can close and need close monitoring. And there's limited freedom, and the patient's often in hospital 2 to 3 days a week, almost for the whole day getting their dialysis. Some complications can include hypotension. Again, we're removing the blood with hemodialysis, filtering it, and putting it back into the patient. Where with peritoneal dialysis, we're infusing fluid in the peritoneal cavity. That fluid is then drawing out the toxins, and we're removing the fluid again. So how do you study this? This was like a lot of reading material for this week. Read your textbook, really concentrate on what I focused on in my 2 PowerPoints, the one on diabetes and this one. Look up YouTube videos, complete the tests at the end of your chapter. Always look through the patient assessment and nursing management when you are reviewing your textbook chapters. Those are often what we see tested on in this course. These 2 test questions I did go over in class. The answer to number 44 is what? A, B, C, or D. Give you a minute to answer that. The answer was B. And slide 45, question number 2. The answer here was C. Remembering that we're in the diuretic phase. We're getting rid of everything. And finally, please remember to complete this story from your course pack as homework to allow you to better understand the material and the content, and to be able to connect it to a patient. So we've already moved on to diabetes because we talked about it in class, but I hope you all have a great reading week, and I'll see you soon.